All right, everyone. Welcome to today's last-minute NCLEX crash review. This session is designed to reinforce the most high-yield concepts that are frequently tested on the NCLEX. Let me be very clear. This exam is not just about memorization. It is about proving that you can think critically and act as a safe nurse. Every question is designed to assess whether you can prioritize patient care, make sound clinical decisions, and above all, protect patient safety. So instead of focusing on cramming endless facts, I want you to shift your mindset toward strategic thinking and prioritization. Today, we're going to break down some of the most frequently tested areas. We'll cover prioritization and delegation, safety and infection control, pharmacology, medication calculations, and then the rest of the lecture will focus on the high-yield topics like restraints and crutches, lab values and ABS maternity and newborn care, high-yield medical surgical conditions, and mental health nursing strategies. By the end of this session, you'll feel much more confident in tackling NCLEX-style questions. So first, how do we tackle NCLEX? The NCLEX has patterns, and if you know how to spot them, you are already ahead of the game. NCLEX is not about memorization. It's about safe nursing. Okay, let me start the lecture with the 3 big tips for the NCLEX exam questions. First, eliminate extreme answers. If you see words like never, always, only, they are usually wrong. Second, for SATA questions, treat each answer as true or false. Do not overthink it. Third, trust your gut. Your first instinct is usually right. If you find yourself over-analyzing, stop. Go with your gut. So stop stressing about cramming every tiny fact. Instead, think like a nurse. Prioritize safety. Use critical thinking. All right, let's get started with one of the most heavily tested topics, prioritization and delegation. NCLEX loves prioritization and delegation questions. When prioritizing patient care, remember the ABCs first. I is for airway. If they cannot breathe, nothing else matters. B is for breathing, hypoxia. Fix it as soon as possible. C is for circulation. Poor circulation leads to organ failure, which is bad. For example, a patient with stridor, airway obstruction versus a patient with a high fever. Stridor takes priority on a patient with an oxygen saturation of 82% versus a patient with a wound infection. Go with the oxygen saturation issue first. Also, don't forget that physical health needs always come before psychosocial needs. If a patient is having a panic attack and another patient is bleeding out, the panic attack can wait. Okay, before we dig in further with more high-yield topics, don't forget to subscribe, like, and follow us. And without further ado, let's dive deeper into the priority and delegation. Okay, you need to be able to tell which patient to see first and last. When you are given multiple scenarios, unstable patients require immediate attention. Examples include new onset symptoms, such as sudden confusion, chest pain, or difficulty breathing. Acute conditions such as stroke, myocardial infarction, or sepsis. Post-operative patients within the first 24 hours. Active bleeding. Severe abnormal vital signs such as hypotension, bradycardia, or hypoxia. What about stable patients? They can wait. Examples include chronic conditions such as chronic obstructive pulmonary disease, diabetes, hypertension. Expected postoperative pain controlled with medications. Discharge-ready patients. So a quick example. A patient with blood pressure of 80/40 and confusion should be seen first. Over a diabetic patient needing insulin can wait. The next, most commonly asked topic is the delegation of work. What are the stuff that RNs must do? And what are the tasks that can be delegated to RPN, or LPN, or WAPS? Firstly, never delegate what you can evaluate, assess, or teach. We call them EAT. Registered nurses handle initial assessments, post-operative assessments and new admissions. They teach new medications, procedures, and discharge education. They administer IV push medications and blood transfusions. They handle unstable patients. They develop care plans and nursing diagnoses. On the other hand, licensed practical nurses care for stable patients only. They administer oral, subcutaneous, and intramuscular medications. But no IV push. They reinforce education that the registered nurse has already provided. They perform wound care, dressing changes, and catheter insertions. Unlicensed assistive personnel assist with activities of daily living, such as bathing, feeding, toileting, and ambulation. They measure vital signs, but only for stable patients. They transport stable patients. Okay, example question. Which task can a registered nurse delegate to a UAP? The answer is ambulating a stable post-operative patient. Monitoring a patient after a blood transfusion is incorrect because that requires an RN assessment. Another frequently asked topic is discharge criteria. Who do we discharge first? When hospital beds are full, you need to free up space. Safely discharge as soon as possible patients who have stable chronic conditions, such as a patient with chronic obstructive pulmonary disease who is stable on home oxygen. Patients with expected post-operative recoveries. Do not discharge if the patient is unstable, has new symptoms, has been post-operative for less than 24 hours, or is at high risk of complications. For example, a stable, chronic, obstructive pulmonary disease patient on home oxygen is safe to discharge, whereas a post-operative patient with a sudden drop in blood pressure should remain hospitalized. NCLEX quick tips to remember. Always prioritize safety. Falls, airway issues, and unstable vital signs must always come first. Do not assume anything. Only consider what is given in the question. If unsure between two answers, choose the safer option. The ABCs in Maslow's hierarchy take priority over everything else. Unstable patients must be seen by a registered nurse. Stable patients can be delegated to an LPN or UAP. All right, class. Now, let's talk about safety and infection control, a topic that NCLEX loves to test you on. Let's start with how to put on PPE. Remember, there's a very easy mnemonic for this. Googles make gowns great. First, you always put on the gown because you need that full body protection. Then you put on the mask or N95 respirator if required, making sure to seal check before entering the room. Next, you put on goggles or a face shield to protect your eyes. Finally, you put on gloves. Always last, ensuring they cover the wrist of the gown. You should always wash your hands first before donning PPE. And if you're using an N95, you must do a seal check before entering the room. Now that you have PPE on, you need to know how to take it off safely, because this is where a lot of mistakes happen. The trick is to remember the order. Gloves, goggles, gown, mask. First, you remove the gloves, since they are the most contaminated. Use the glove and glove technique, or peel them from the inside out. Next, you remove goggles or a face shield, making sure not to touch your face. Then you take off the gown by untying it at the back and rolling it inward, so the contaminated side stays inside. Lastly, you remove the mask. Always last, and if it's an N95, you must remove it outside the room to avoid inhaling airborne particles. You must wash your hands immediately after removing PPE. Gloves first, mask last. Prevents contamination. Now, let's talk about isolation precautions, because NCLEX frequently tests this topic. Airborne infections are those that float in the air, requiring an N95 mask. The mnemonic to remember is "My chicken has TB," which stands for measles, chickenpox, herpes zoster, disseminated shingles, and tuberculosis. These patients require a private room with negative pressure to prevent the infection from spreading outside. An N95 respirator is mandatory for anyone entering the room. And if the patient has to leave the room, they must wear a surgical mask. If you are asked, which patient should be placed on airborne precautions? The answer is always someone with tuberculosis, because they require an N95 mask and a negative pressure room. Respiratory syncytial virus, or RSV, is a droplet precaution, not airborne. What about droplet? Droplet infections spread through coughing, sneezing, or talking. So a surgical mask is required. The mnemonic to remember is Spider-Man, which includes sepsis, scarlet fever, strep pharyngitis, pertussis, pneumonia, influenza, diphtheria, epiglottitis, rubella, mumps, meningitis, and adenovirus. A private room is preferred, but if necessary, patients with the same infection can be placed together. Healthcare workers must wear a surgical mask when within 3 to 6 feet of the patient. And if the patient leaves the room, they must wear a surgical mask as well. If you are asked what PPE should be worn for a patient with bacterial meningitis, the correct answer is a surgical mask, because meningitis is droplet precaution, not airborne. Okay, next contact. Contact infections spread through direct contact, meaning you must wear a gown and gloves for any interactions. The mnemonic to remember is MRSWE, which includes multi-drug resistant organisms like MRSA and VRE, respiratory infections like RSV, skin infections like scabies and impetigo, wound infections, enteric infections like Clostridium difficile, and eye infections like conjunctivitis. These patients should be in a private room, or they can be cohort with another patient who has the same infection. You must always wear a gown and gloves when interacting with the patient. And in the case of Clostridium difficile, you must wash your hands with soap and water, because alcohol-based hand sanitizers do not kill spores. If you are asked, which patient should be placed on contact precautions? The correct answer is someone with MRSA, because they require both a gown and gloves. However, if the patient has measles, they should be on airborne precautions and need an N95 mask. Okay, some NCLEX tips for you. You must remember that tuberculosis, measles, and varicella are always airborne, requiring an N95 mask in a negative pressure room. Influenza and meningitis require droplet precautions, meaning you need a surgical mask and must stay at least 3 to 6 feet away from the patient. MRSA, Clostridium difficile, and RSV require contact precautions, meaning you must wear a gown and gloves. If a patient has Clostridium difficile, you must wash your hands with soap and water, because alcohol-based hand sanitizers will not kill the spores. Lastly, always remember that when doffing PPE, gloves come off first, and the mask comes off last to prevent contamination. Now we are going to focus on high yield, must-know drug toxicity levels, major side effects, black box warnings, and of course antidotes. First up, let's talk about toxic drug levels. Some medications have a narrow therapeutic range, meaning that just a little bit too much can push the patient into dangerous territory. This is why monitoring levels is so important. Let's go over the big ones you need to know. Digoxin, used for heart failure and arrhythmias. Normal range 0.5 to 2.0. Over 2.0, and we start seeing toxicity. Classic signs: nausea, vomiting, and this is the kicker: vision changes like difficulty reading or seeing yellow-green halos. If your patient says, "Everything looks like Van Gogh's Starry Night," you know what's up. Lithium, used for bipolar disorder. Normal range 0.6 to 1.2. Once it hits 1.5 or higher, we're in toxic territory. What does that look like? Extreme thirst, excessive urination, nausea, vomiting, and diarrhea. Basically, your patient is drying out. Phenytoin, an anti-seizure medication. Normal range 10 to 20. Go above 20 and you get ataxia, which means the patient looks like they're drunk. Unsteady gait, hand tremors, slurred speech. If they're stumbling and mumbling, that phenytoin level needs checking. Theophylline, a bronchodilator. Normal range 10 to 20. Over 20. And we're worried about seizures. Not fun. Acetaminophen. That go-to pain reliever. Normal range 10 to 30 micrograms per milliliter. But at 150 to 200 micrograms per milliliter, we're looking at serious liver damage. Remember ALT and AST are your best friends when monitoring for liver failure. So again, digoxin toxicity is vision changes, yellow. Green halos, nausea, bradycardia. Lithium toxicity is tremors, confusion, nephrotoxicity, kidneys. Phenytoin toxicity is ataxia, unsteady gait, slurred speech. Theophylline toxicity is seizures, dysrhythmias. Acetaminophen toxicity is liver failure. So you have to check ALT/AST. So what do we do if we suspect toxicity? Stop the medication immediately and check labs. If needed, administer the antidote. Speaking of antidote, let's talk about those now. Antidotes are life-saving, and NCLEX loves to test you on them. Let's go through the key ones. Opioid overdose, give naloxone. Acetaminophen overdose, give N-acetylcysteine. It protects the liver. Magnesium sulfate toxicity, give calcium gluconate. Heparin overdose, give protamine sulfate. Warfarin overdose, give vitamin K. Digoxin toxicity, give digibine potassium overload. Remember BK, bicarb, insulin, glucose, and kexalate. Alcohol withdrawal. We use benzodiazepines. Calcium channel blocker overdose. Treat with calcium gluconate. If you can memorize even just a handful of these, you'll be golden on test day. Now, let's talk about black box warnings. These are the FDA's highest safety warnings, and they must be taken seriously. Let's start with beta blockers. Anything ending in LOL like metoprolol or propranolol. Remember ABCD for their key risks. Asthma, they can cause bronchospasm, so we don't give them to asthma patients. Bradycardia, they slow down the heart rate and can cause heart block. CHF, in severe cases, they can worsen congestive heart failure. Diabetes, they mask hypoglycemia, which is dangerous for diabetic patients who rely on early symptoms like shakiness and sweating. Other important black box warnings. ACE inhibitors, Pril. Drugs like lisinopril can cause angioedema, swelling of the face, lips, and tongue. This is a medical emergency. Antidepressants, SSRS, SNRIs, TCS. Increased risk of suicidal ideation, especially in young adults. QT prolongation drugs. Many medications can prolong the QT interval, increasing the risk of fatal heart arrhythmias. So to recap, know your toxic drug levels. Lithium, digoxin. Theophylline, phenytoin. Acetaminophen. Memorize key antidotes, naloxone. Vitamin K, digibine, etc. Stop the drug and check labs if you see toxicity signs. Understand black box warnings like beta blockers, ACE inhibitors, antidepressants, and QT prolonging drugs are big ones. Alright class, let's get into medication calculations. I promise this is going to be fun. Well, as fun as math can be. But don't worry, I'm going to make sure you never mess up. A dosage calculation on the NCLEX. You will get at least 1 or 2 calculation questions. In the NCLEX, we're starting with the basic dosage formula. It's super simple. D divided by H times Q equals X. Remember D divided by H times Q equals X. D stands for desired dose. That's what's ordered. H is what you have on hand. Q is the quantity, the form of the drug. Whether it's 1 tablet 5 milliliters, or whatever unit you're working with. And X is the amount you need to give. Got it. Perfect. Let's do an example. Your order says to give 50 milligrams of a drug, but what you have available is 25 milligram tablets. So we plug it into our formula. 50/25 times 1 tablet. That gives us 2 tablets. Easy, right? One more example, the order is 600 milligrams of amoxicillin. And what we have available is 200 milligrams per 5 milliliters. Plug it in 600/200 by 5 milliliters. That means we need to give 15 milliliters. Boom, that's how you do it. Now, let's talk IV flow rates. This is where things get a little more fun, because we're dealing with pumps and gravity. First, let's go over the formula for milliliters per hour. Total volume divided by time in hours equals your rate. Simple, right? Here's an example. The order says to give 1,000 milliliters of normal saline over 8 hours. So we do the math. 1,000/8, that gives us 125 milliliters per hour. That's what you'll set your IV pump to. Quick NCLEX tip. Always round to whole numbers for IV pumps. No decimals allowed. Now let's talk about drip rates. That's when we don't have a fancy pump and have to count drops per minute. Here's the formula. Total volume times drop factor divided by total time in minutes equals drops per minute GDT per minute. Example time. You need to give 1,000 milliliters over 8 hours. The drop factor is 15 GDT per milliliter. First, convert hours to minutes. 8 hours times 60 minutes equals 480 minutes. Now plug it in 1,000 times 15/480. That gives us 31.25 drops per minute. But remember, we round to a whole number, so we set it to 31 GDT per minute. Alright, last calculation. Weight-based dosages. This is where we really need to pay attention, because weight-based meds can be tricky. The formula is simple. Weight in kilograms times dose. Milligrams per kilogram equals total dose. And before we even start, always convert pounds to kilograms. First, 1 kilogram equals 2.2 pounds. Write that down, tattoo it on your arm. Whatever helps you remember. Example time, the order is for acetaminophen, 15 milligrams per kilogram. The patient weighs 44 pounds. First, convert the weight. 44 pounds divided by 2.2 is equal to 20 kg. Now multiply 20 kilograms times 15 milligrams per kilogram equals 300 milligrams. And that's your answer. 300 milligrams. See, medication calculations aren't scary. It's just plugging numbers into formulas and double-checking your work. And the more you practice, the faster you'll get. And just remember, when in doubt, always check your work and never round too soon. Restraints and crutches. Now, I know, it might not sound like the most thrilling thing, but trust me, it's crucial for the NCLEX. And it's one of those things you need to know, inside and out. So let's make it fun and engaging as we go through this. First off, when do we use restraints? And what are some alternatives we should try first? The golden rule here is, restraints should only be used as a last resort. You can't just slap restraints on someone, because it's easier. The NCLEX is very clear on that. So when can you use restraints? Only to prevent harm to the patient or others. This isn't just a rule. It's a legal and ethical standard. You're going to need a provider's order. And yes, you can get that order after applying restraints in an emergency, but you better follow up and document it properly. Let's look at some examples of when you can use restraints. Imagine you're dealing with a violent patient who's trying to harm staff or themselves. Restraints can be used here. Or maybe you have a post-stroke patient who keeps trying to pull out their IV or feeding tube. You might need to consider restraints in that case. And then there's the classic, a confused patient trying to get out of bed, even though they're a high fall risk. And this is a big but. There are times when you should not use restraints. You never use them for patient convenience. Just because they're agitated or annoying doesn't mean you get to take the easy way out. And for dementia patients who are wandering around, you've got to try alternatives first, Let's talk about those alternatives. So what should you try before jumping to restraints? First, reorient the patient. Explain what's happening. Sometimes a simple explanation can calm them down. You can move the patient closer to the nurse's station. That way you're keeping a closer eye on them. Bed alarms are a fantastic option. They alert you if they're trying to get up. If the patient's family is around, encourage them to sit with the patient. Sometimes a familiar face can make all the difference. And distractions gold. Turn on the TV, play some music, have a conversation. It can help keep them settled. Finally, use low beds and mats to reduce the fall risk. If they do get out of bed, here's a quick NCLEX tip. If you see an answer, choice about trying a less restrictive method first. Pick that one. Always go for the least restrictive option before jumping to restraints. Let's do a quick example question. A confused patient is trying to pull out their IV. What should the nurse do first? Cover the IV site with a protective sleeve, because that's a less restrictive option. Applying wrist restraints immediately. Nope, try alternatives first. Alright, now let's switch gears a bit and talk about crutches. You're gonna see questions about proper crutch fit and gait patterns. So let's make sure you've got this down. When it comes to proper crutch fit, you need a 2 to 3 finger gap between the armpit and the crutch top. Not more, not less. Just right. And the elbows. You're aiming for about a 30-degree flexion when holding the handles. This helps keep the weight on the hands, not on the armpits. Why is that important? Because putting weight on the armpits can cause nerve damage. We're talking about axillary nerve damage, also known as crutch palsy. So remember, weight goes on the hands, never the armpits. Now, let's talk gait patterns. The type of gait pattern used depends on the patient's weight-bearing ability. Let's break it down. First up, the 2-point gait. This one's for partial weight bearing on both legs. The patient moves the opposite crutch and leg together. It kind of mimics a normal walking pattern. This is great for patients with minor leg weakness. Then there's the 3-point gait. This one's for non-weight bearing on one leg. Think fractures, sprains, or surgery. On one leg, the patient moves both crutches forward. Then the good leg steps up. Finally, we have the 4-point gait. This is for full weight bearing and maximum stability. It's crutch opposite leg, one step at a time. You'll use this for patients with severe weakness, like with neuro disorders. Going up and down stairs with crutches. There's a mnemonic for that. Up with the good, down with the bad. Going up, lead with the good leg. Then the crutches, then the bad leg. Going down, crutches first. Then the bad leg, then the good leg. Easy to remember, right? Quick NCLEX tips to wrap this up. Restraints are a last resort. Always try alternatives first. When you secure restraints, tie them to the bed frame, not the side rails. And check every 15 to 30 minutes. Crutches. 2 to 3. Finger gap under the armpits to avoid nerve damage. And remember, up with the good, down with the bad on stairs. Alright, everyone, super important topic. Lab values and ABG interpretation. This is a high-yield topic for NCLEX. And we're going to break it down in a way that makes it easy to understand and remember. So let's get started. While they won't necessarily ask you to recall exact numbers from memory, you'll need to recognize abnormal values and know what they indicate. Many NCLEX questions present lab results as part of a case scenario, and you'll have to interpret whether they're normal or concerning and what actions to take. So, while you don't need to memorize every single lab value, you should be very familiar with the most commonly tested ones, like sodium, potassium, calcium, magnesium, ABGs, and coagulation labs, because they directly impact patient safety. Having a good grasp of these values before going into the exam will make it easier to quickly identify critical issues and choose the right interventions. So, electrolytes, the basics. Electrolytes are essential for body function, And even small imbalances can cause major issues. You need to know these normal ranges. And what happens when they're off? Sodium's normal range is 135 to 145. Sodium imbalances affect the brain. Too high or too low. Think neuro changes, seizures, confusion, even coma in severe cases. If you see a patient with mental status changes, check that sodium, potassium. Potassium's normal range is 3.5 to 5. Potassium is all about the heart. High potassium, you'll see peak T waves and arrhythmias. Low potassium, the heart gets irritable too, leading to dysrhythmias. Watch those levels closely. Normal range of calcium is 8.5 to 10.5. Calcium affects muscle function. Low calcium, think tetany muscle spasms. Chvostek sign, like face twitch when tapped. And Trousseau's sign, like carpal spasm with a BP cuff. High calcium muscle weakness and decreased reflexes. Magnesium's normal range is 1.5 to 2.5. Magnesium controls reflexes. Low magnesium hyperactive reflexes. High magnesium depressed reflexes. It also plays a big role in cardiac function. So keep an eye on that for arrhythmias. Phosphorus's range is 2.5 to 4.5. Phosphorus is linked to calcium. When one goes up, the other goes down. High phosphorus kidney issues. Low phosphorus bone issues. Easy to remember. Chloride's normal range is 95 to 105. Chloride helps with acid-base balance. If it's off, your patient might be dealing with metabolic or respiratory imbalances. For the NCLEX tip, electrolytes. Electrolyte imbalances cause specific symptoms. So focus on what body system is affected. Sodium affects brain. Potassium affects heart. Calcium and magnesium affects muscles. Phosphorus affects bones and kidneys. Now, let's dive into arterial blood gases abs. These tell us how well the lungs and kidneys are balancing pH. First, you have to know the normal ABG ranges. pH is between 7.35 and 7.45. PaCO2, which is the partial pressure of carbon dioxide in arterial blood. The normal range is 35 to 45 millimeter of mercury, and this deals with the respiratory component. Bicarb's normal range is 22 to 26, which deals with the metabolic component. Respiratory versus metabolic imbalance. If pH and CO2 are moving in opposite directions, it's respiratory. If pH and HCO3 are moving in the same direction, it's metabolic. So once you remember these normal ranges, let's figure out how to solve such questions. First, you look at the pH value and see if it is acidic or alkalotic. If pH is lower than normal range 7.35, it is acidosis. If it is higher than 7.45, it is alkalosis. Then next you are going to look at the partial pressure of carbon dioxide and bicarb and see if they are lower or higher than their own normal range, and see if the trends of their own are the same or opposite to the trend of pH. And there is a memory tip here. Remember a word ROME. Respiratory opposite, metabolic equal. So we say it is respiratory if the trend of pH and CO2 are the opposite, and metabolic equal. We can tell it is metabolic if the trend of pH and bicarb are the opposite. So let's say pH is lower than the normal range. So it is acidosis. And if the CO2 level is higher than its normal range, it is respiratory acidosis. Remember ROME, the mnemonic for respiratory opposite. Metabolic equal. If CO2 and pH are opposite, it is the respiratory issue. If bicarb and pH move together, it is the metabolic issue. Common ABG conditions for each of them are important. 2. Respiratory acidosis is when low in pH and high CO2. For this, think hypoventilation like COPD, pneumonia, and sedation. Respiratory alkalosis is when high in pH and low in CO2. For this, think hyperventilation like panic attack, fever. For metabolic acidosis, think DKA, kidney failure, diarrhea. and for metabolic alkalosis, when high in pH and high in bicarb. Think vomiting, excess antacid use. Okay, let's shift gears and talk about complete blood count, CBC, and coagulation studies. WBC, white blood cells. Normal range is 4,000 to 11,000. Low WBC, high infection risk. High WBC infection is present. RBC, red blood cells. Normal range is 4.2 to 6.1 million. This tells us about oxygen carrying capacity. Low RBC, think anemia. High RBC, think polycythemia. Too many red blood cells. Hemoglobin and hematocrit. Hematocrit's normal range is 37 to 52%. Low levels anemia, high levels dehydration, or polycythemia. Platelets. Normal range is 150,000 to 400,000. Low platelets means high bleeding risk. That means if your patient is on heparin or aspirin, you need to check those levels before giving the meds. What about coagulation labs? PT, the prothrombin time, is normally between 11 to 14 seconds. If you are on anticoagulants, 1.5 to 2 times normal, we check the INR. If you are on warfarin, normal range INR is 0.8 to 1.2. But if you are on warfarin, the therapeutic range is 2 to 3. APT is measured for heparin. The normal range is 30 to 40 seconds. Therapeutic range, when you are on heparin, is 60 to 80 seconds. NCLEX tip for the coagulation labs. If platelets are low, bleeding risk is high. So hold heparin or aspirin. If INR is too high, warfarin needs to be adjusted. Always monitor these levels closely. Let's now dive deep into fetal heart rate patterns, stages of labor, postpartum care, and of course, those high-yield NCLEX tips you need to pass. Let's start with fetal heart rate patterns. You might have heard of ALCHOP. This is how we match decelerations with their causes. First up, variable decelerations. These are caused by cord compression. The baby's umbilical cord is getting squeezed. So what do? Move the mom. Reposition her, left side, right side, hands and knees. Whatever gets that cord free. Easy fix, early decelerations. Totally normal. This happens because of head compression. As the baby moves down, no need to panic. Just means labor is progressing. Give mom a high five, because she's doing great. Accelerations, that's a sign of good oxygenation. No intervention needed. In fact, we love accelerations if you see them. Smile and move on. Now, the one we don't want. Late decelerations. This means placental insufficiency. Baby isn't getting enough oxygen. So what's the game plan? Stop Pitocin. Reposition mom, give oxygen, and start IV fluids. This is an emergency, so act fast. Quick NCLEX tip. Late decels equals BAD. Early decels, no worries. Variable decels, move the mom. Now, let's talk stages of labor. Knowing when to intervene is key. Stage 1 is when dilation and contractions begin. This stage has 3 phases. First phase is the latent phase. This is between 0 to 3 centimeters. Contractions are mild and mom is chatty. She's cracking jokes, texting her friends. Life is good. Active phase is when it stretches to 4 to 7 centimeters. Contractions are stronger, and mom is now serious. No more chit-chat. She's focused, maybe breathing heavy. This is where the real work begins. Transition phase is between 8 to 10 centimeters. This is intense. Mom feels like she's dying. She's not, but it feels that way. Lots of shaking, nausea, and yelling. Totally normal. When do we intervene? If contractions last more than 90 seconds or are less than 2 minutes apart. That's too strong. This is called uterine tachysystole. Also, if mom is pushing at 8 centimeters, tell her to stop and breathe. It's too early. The stage 2 of labor is pushing and birth part. Mom is now fully dilated. This is go time. Time to push. Expect crowning. That baby is almost here. When do we intervene? If mom has been pushing for hours with no progress, we might need forceps or a vacuum. If the baby's head delivers, but the shoulders get stuck, shoulder dystocia, we do the McRoberts maneuver. Knees to chest and apply suprapubic pressure. Stage 3 of labor and delivery. Placenta delivery. The placenta should deliver within 5 to 30 minutes after birth. What's not normal? If it takes longer than 30 minutes, that's a retained placenta. Call the provider. If mom is bleeding a lot, massage the fundus and give oxytocin to help the uterus contract. Stage 4 is the recovery, which is the first 1 to 2 hours postpartum. This is when we watch for postpartum hemorrhage. The biggest risk right now. We check vitals, fundal height, and lochia every 15 minutes. If the fundus is boggy soft, not firm, massage it ASAP. If bleeding is excessive, soaking more than 1 pad per hour, that's bad, intervene now. Postpartum hemorrhage and fundal assessment. What's considered postpartum hemorrhage? For vaginal birth, when there is more than 500 milliliters blood loss. For C-section, when there is more than 1,000 milliliters blood loss. Priority actions for postpartum hemorrhage are important. Massage the fundus first and check for bladder distension. A full bladder pushes the fundus to the right. Give oxytocin, pitocin, and if needed methargin or hemabate. Watch for hypovolemic shock, like low blood pressure, high heart rate, pale, weak. Then who's at high risk for PPH? With prolonged labor, twins, triplets, big baby more than 8.8 pounds. Uterine atony is like boggy uterus and gone bad. Okay, NCLEX loves fundal assessment as well. After birth, the fundus should be at the umbilicus. Then it moves down 1 centimeter per day. By day 10 to 14, it should be back in the pelvis. You shouldn't be able to feel it. But what if the fundus is above the umbilicus or shifted? That means mom's bladder is full. Have her empty it. Now let's talk about some high-yield Med-Surg topics. Heart failure. Now heart failure comes in 2 flavors, left-sided and right-sided. And the best way to remember them. Think of L for lungs and R for the rest of the body. Left-sided heart failure means the heart isn't pumping blood forward effectively, so it backs up into the lungs. What does that mean for our patients? Pulmonary congestion. Symptoms include shortness of breath, crackles in the lungs, dyspnea, orthopnea. That's difficulty breathing when lying flat. And the classic frothy, pink sputum from pulmonary edema. On the other hand, right-sided heart failure backs up into the body. Instead of lung symptoms, we see systemic congestion. Think swelling everywhere. Peripheral edema, jugular vein distension, ascites and hepatomegaly, which is an enlarged liver. All of this is due to fluid overload. Quick NCLEX tip. First-line medications for heart failure. Diuretics to pull off excess fluid. And ACE inhibitors to reduce afterload and help that heart pump more efficiently. Boom, simple, right? Moving on to another critical NCLEX topic, strokes. And let me tell you, time is brain. Recognizing the signs early can make all the difference. So here's a quick way to remember it. FAST. F is for face drooping. Ask the patient to smile. One side might not move. A is for arm weakness. One arm drifts down when they try to lift both. S is for speech difficulty. If they're slurring their words or can't repeat a simple phrase, that's a big red flag. T is for time because you need to call 911 ASAP. Now let's talk treatment. There are 2 main types of strokes, ischemic and hemorrhagic. Ischemic strokes. These are the most common, caused by a clot blocking blood flow. If caught early, we can give TPA, a clot-busting medication, but only within 3 to 4.5 hours of symptom onset. And here's the key, you must do a CT scan first to make sure there's no bleeding before giving TPA. Hemorrhagic strokes, no TPA. Instead, we need to focus on stopping the bleeding, which could mean surgery, blood pressure control, and avoiding anything that could thin the blood. So no aspirin, no heparin, no anticoagulants. All right, let's switch gears to diabetes emergencies. DKA and HHS. Two different conditions, but both serious. DKA, or diabetic ketoacidosis, happens in type 1 diabetics and is all about acidosis. Blood sugar is usually 250 to 500 plus. And the key signs? Kussmaul breathing, that deep rapid breathing, trying to blow off acid, fruity breath, and metabolic acidosis. The treatment, IV fluids first, then insulin. And don't forget, you need to replace potassium, because insulin drives potassium into the cells, which can cause dangerously low levels. Now, HHS, or hyperosmolar hyperglycemic syndrome, happens in type 2 diabetics. Blood sugar is crazy high, 600 or more. But here's the difference. No ketones, no acidosis, but severe dehydration and neurological changes like confusion and coma. The treatment plan is similar. IV fluids first, then insulin. But we're not as worried about acidosis like in DKA. And there you have it, some of the highest yield topics you need to know for the NCLEX. Just remember heart failure, L for lungs, R for rest of the body, stroke, fast diabetes emergencies. DKA is all about acidosis and ketones. HHS is severe dehydration. Psyche is where a lot of students trip up. But after today, you'll know exactly how to approach these questions with confidence. First things first, therapeutic communication. If there's one golden rule, it's this. Always encourage the patient to express their thoughts and feelings. That's your go-to mindset when answering NCLEX questions. So, let's talk about what therapeutic communication actually looks like. If a patient says they're feeling overwhelmed, you reflect their feelings back. It sounds like you're feeling really overwhelmed. If they say they feel trapped, you clarify. When you say you feel trapped, what do you mean? If they're struggling to open up, you use open-ended questions. What has been on your mind lately? And sometimes you say nothing at all. Silence is powerful. It gives them space to process and share more. Now, let's go over what not to do. If you see one of these responses on the NCLEX, do not pick it. Never ask why. Saying, "Why do you feel that way?" comes across as judgmental. Never give false reassurance. "Don't worry, everything will be fine." That just shuts down the conversation. Never minimize feelings. You should just try to stay positive. That's dismissive. Never make it about yourself. "I know exactly how you feel." No, you don't. Never block communication. "Let's not talk about that right now." That's a big red flag. All right. Now let's talk about schizophrenia and hallucinations. Schizophrenia symptoms come in two categories. Positive symptoms, things added to reality like hallucinations, delusions, and disorganized speech. Negative symptoms, things that are missing like a flat affect, social withdrawal, and lack of motivation. Now, hallucinations are sensory, seeing or hearing things that aren't there. Delusions, on the other hand, are fixed false beliefs, like "I'm the President of the United States." And paranoia, that's when someone is suspicious of others, like "the nurses are trying to poison me." So how do you respond when a patient is hallucinating? First, acknowledge their feelings while staying in reality. Say something like, "I understand that you hear voices, but I don't hear them." Redirect their attention to something real. Let's focus on what's happening here in the room. Ensure safety. If they're hearing voices, ask, "Are the voices telling you to hurt yourself or others?" And what do you never do? Never argue. Saying, "That's not real," stop talking about it, just shuts them down. Never validate the hallucination. Saying, "I hear the voices too," is a big no. Never encourage fixation. Saying, "Tell me more about the voices," just keeps them focused on the hallucination instead of reality. All right. Next, delusions and paranoia. If a patient believes something that isn't true, acknowledge their feelings without arguing. Say, I understand that's how you feel, but let's focus on what's happening right now. Encourage reality-based thinking. Maintain a calm, structured environment. Routine equals safety. What do you not do with delusions? Never say, that's not true. That just makes them more defensive. Never ask why they believe something. It feels confrontational. Now, before we wrap up, let's go over some quick NCLEX test-taking tips. Safety first. Always prioritize patient safety before anything else. Follow ABC's airway breathing. Circulation unless safety is a concern. For select all that apply, SATA questions. Treat each option as true or false. Don't second-guess yourself. Be wary of 100% words like never. Always only. They're usually wrong. And finally, your mindset matters. Stay calm. Trust your preparation and avoid last-minute cramming. A good night's sleep will do more for you than an extra 2 hours of studying. You got this. The NCLEX isn't about being perfect. It's about being safe. So go in with confidence. Read carefully and trust yourself.